Well, I don't want to be too negative. I think it's important that we have made the progress. I'm just thinking about how do we increase better use. Sean, what do you think about that?
I guess my concern is that the transition, from my perspective, was actually relatively rapid, as Dr. Cale was mentioning, transitioning to the NOACs. But the problem has been there hasn't been that increasing trajectory of overall use of anticoagulation in these patients. And I think the guidelines are pretty clear on this as well. When we talk about the guidelines and the importance of shared decision making and engaging patients in decision making, I think we've done some studies with qualitative interviewing within the Duke health system, looking in primary care practices and geriatrics practices, and there's been several other studies that have shown this too. There's still a fundamental disconnect with the way that patients see the world and the way that providers see the world. And I think that's one of the things that we really need to work to overcome. The number of bleeds that a patient is willing to tolerate to prevent a stroke is much higher than the number of bleeds that a provider is willing to tolerate. And
so I love this study, Sean. Yeah. So the study, I oversimplify it a little bit, but basically the study showed when you go to you take a population of patients who are not on an anticoagulant for atrial fibrillation, you go and you ask the patient, you go and you ask the providers, why aren't they on it? And the provider says, because the patient refused. They didn't want the high risk. You go to the exact same patient and you get a completely different answer. Yep. It's because it wasn't described to them that the benefit clearly outweighed the risk.
And I think physicians, in fact, there's been a questionnaire, the survey carried out in Canada. Physicians were frightened of bleeding because we cause bleeding. Patients were frightened of stroke.
Yes.
And I think that the underutilization is the fault of physicians, not patients.
And certainly I think some of the data you're describing, they numerically ask patients, how many GI bleeds, how many bleeds requiring hospitalization, how many of these falls would you take with a bleed that might get you to the hospital? And they're in the hundreds, in their minds, 50s. And we see one and feel very bad about it because, of course, we're trained in the do no harm and want to make decisions, but involving them would help.
Yeah, I mean, I still love the New York Academy of Medicine phrase. It shouldn't be do no harm. It should be on average do more good than harm.
Yeah, right.
Because everything we do that causes good carries some risk.
Of course.
I think this is where, to me, it's really interesting to engage our neurology colleagues because we see the bleeding episodes that patients have.
They see the strokes.
They see the strokes. And so when you talk to the neurologists, they really highlight what a huge issue it is in these patients and how life-changing it is. We know that AFib-related strokes, almost 25% of people die within 30 days. They have much higher morbidity relative to non-AFib-related strokes. These are large disabling strokes.
So, and certainly bleeds in the brain are one of those most disabling effective things that we can see. And so one of the hazards and risks we can think about together is something that probably with these therapies made a big difference. And so maybe I'll end our sort of thought about how do we got from 2010 to 2020 and then get into our sort of how do we do better now by saying what I've heard from you all is obviously don't overvalue any effective aspirin in atrial fibrillation stroke prevention. I think we would all agree that that is a therapy that is not making much difference to these patients with atrial fibrillation.
Except causing some harm.
Except causing some harm. So on average, you're not going to be able to do more good than harm if you're giving an AFib patient at least aspirin most of the time, unless there's some other thing you're trying to treat. Second is maybe the adoption's gone faster than we think, but these drugs met a high bar and have evolved pretty quickly, and we can talk about the separate NOACs in a second. And this is despite different mechanisms of action. Dabigatran with, let's say, a direct thrombin versus the factor Xa, which edoxaban, apixaban, and rivaroxaban certainly have targeted and shown, again, similar efficacy against warfarin when we think about the place the world was in.
And there's one other really important thing about warfarin and intracranial hemorrhage, and we've seen this in the trials where we have robust data sets, and that is that if somebody who has an intracranial hemorrhage on warfarin, 80% of the time their INR is in the target range or not above 3.
Yeah.
So this misperception that if you have somebody on warfarin and their INR is below 3, that they're not at risk is a fallacy.
Yeah, in the trials, in fact, we demonstrated a significant portion of the patients that were having the ICHs in the trials, their last known INR, we didn't always get the INR right when they presented, was within range, but of course that's something we didn't.
Manesh, maybe one perspective that's bringing out in me that I worry about a lot is how do we get the world to understand the difference between things that are really empirically proven with really good data and high quality studies versus all the other, I don't know what to call it, all the other stuff that people believe which may or may not be true, including doctors and health systems. And in this case, there are hundreds of thousands of people now in randomized trials with good data collection, oversight, and questioning by many people. So this is one area where you really ought to be able to put the post down and say, this is proven stuff. It's not just somebody's opinion.
It is interesting sometimes to look at the differences in guidelines. Now, the European guidelines for some time have said that aspirin is a class 3 indication, antiplatelet agents for atrial fibrillation. The ACC-AHA guidelines, until recently, the most recent reiteration took that out, but until recently, it said that if you are a CHA2DS2-VASc of 1, so you're at increased risk, even if slightly, you could use aspirin or an anticoagulant or nothing, which really left it up in the air. And it's only now that I think our guidelines have really looked at the evidence that has been taken up by other guidelines and said, do not use aspirin, which is...
I think that's absolutely powerful. And Rob, to your point, I sometimes put it this way. Let's do the counterfactual. What if we have now 79,000 or 80,000 patients randomized in high-quality 4 trials to show that these agents are better than warfarin? What if I did it the other way? Warfarin is clearly better than placebo in 6,000 patients, and that's how we got to now. If I had 79,000 patients and the pricing and the use of these drugs had 5 years, and then I came to you with warfarin and said, here's what the drug looks like, here's what the efficacy is, this is how you have to treat patients with it, would you be using it in anyone?